literally the best part of coming home. Hi. Hi. Hello. Hi. Hey. Hi. Hey, come here. Oh, hey. Oh, there's also a cat here. Got that.
Yeah, I am on my last rotation of med school. That's quite a phrase. Now I know what you're thinking. You're like, Andy, it's like November, December. How are you on your last one? It's all my curriculum. I front loaded all my requirements. So basically after this, it's purely elective. But as far as all the clinical rotations that I need to to graduate, it's all done. So this is it. And I really do think it's fitting that the last rotation is critical care or ICU, because when I tell you it really is the most advanced rotation in medical school, I mean it. But thankfully there's actually a lot of similarities between critical care and anesthesia. So surprisingly, a lot of it has not gone too far over my head over the past 4 weeks.
A typical day begins getting to the hospital around 7 a.m. to meet up with the night team for overnight handover. They will tell us if any significant overnight events happened with our patients and if there is anything that needs to be immediately addressed today as far as medications, procedures, or further discussions with consultants or even family. Thankfully, this hospital gives the students free food and, more importantly, coffee, so the next plan of action usually involves grabbing breakfast and coffee before heading upstairs to the student or resident library to print out an updated patient list. This is where most of the learning for me happens, as I read up on the notes written from the previous day's team, including nurses, pharmacy, PT, social work, specialist consultants, etc., so that I am following the timeline of treatment and I can at least come up with an idea of how we can move each patient forward a little bit better today. As you can imagine, patients in the ICU are the sickest of the sick and are on literally all the big gun antibiotics and have some of the most rare microbial infections. Thankfully, I still got some knowledge from this video sponsor, Sketchy, but a little refresher never hurt anyone. Their cartoons have quite literally helped cement all my antibiotics and microorganisms in my head since first block of med school, and I still call upon that knowledge and Sketchy spatial learning to this day to remember antibiotic coverage. And even when I do forget, the videos are just one click away and the memories all come flooding back, especially for the big guns that fight MRSA, ESBL, and any other scary bug growing in our ordered cultures. Even if I need a little more help, I can quiz myself with their built-in assessment tools. Can't recommend using Sketchy enough to any medical student, and to try it yourself, act fast and get 20% off, no code needed for this year's Black Friday sale up to 11/30/2023. Don't miss out. After I'm caught up on my chart review and have come up with some plan suggestions, it's off to the unit for multidisciplinary rounds to discuss each patient's plan for the day with the entire team of doctors, nurses, RT, PT, speech therapists, nutritionists, pharmacists, social workers. Yeah, as you can tell, critical care requires quite the team to make sure we get patients healthy enough to hopefully leave the ICU. After rounds, which take anywhere from 2 to 5 hours, it's off to lunch, complete any procedures needed, and then we go home to pet our emotional support doggos. It's a spindrift, not a beer. Although, hold on, let the dog. Hi, join me. Okay, what was I saying? Honestly, it's really nice coming from an anesthesia rotation. I was at Texas Children's doing a pediatric anesthesia rotation right before this, because there's a lot of similarities between anesthesia and critical care. In fact, a lot of the data that we use in anesthesia comes from critical care studies, so obviously there's a big connection there. I will say I definitely miss the kids, being around pediatric patient populations a lot more, but I mean, adults make up way more of the patient population, so no way around it. But yeah, critical care is like if you took the job of an anesthesiologist and split it up into like 6 roles. So you delegate, your respiratory therapist, your pharmacist, the role of the physician, nurses giving the medication, split up their job into like multiple different roles, and then you make the workflow at the pace of a snail on Versed, and you basically got critical care. Sprinkle in a little bit of internal medicine, and by a little bit, I mean a lot of internal medicine, and yeah, that's basically your day. For those interested in critical care, there's a lot of different ways to go about it. Most common is internal medicine to critical care, and then you get a lot of anesthesia to critical care. And then apparently one of my attendings was gen surge to crit care and does both. So a lot of opportunities to go into it if you want, but I would definitely say see if you like hospitalist medicine before you go to critical care, because it's kind of paced the same, but way more medically complex. In the ICU, you're basically taking over like every basic physiologic function, like you're breathing, you're circulating for a person. Sometimes you are quite literally their kidneys, which is really cool. But one difference between critical care and internal medicine is I think you have to be much more patient in critical care and be much more okay with setbacks, because things can get really, really better instantly or really, really worse also instantly, and that typically doesn't really happen on the hospital floor or even step-down units. Like somebody in acute hypoxic respiratory failure can be improving for days on a vent and then all of a sudden collapse from vent-associated pneumonia, or somebody who we thought like honestly wouldn't make it out of the ICU, all of a sudden randomly their kidney function starts improving and they start like moving spontaneously, and we're like, huh, okay. But it's all about little changes. You're not going to see significant improvements usually day by day by day. It takes time, and so this is a field where a lot of patience is needed. And not just on the patient side, rounding. Have I mentioned I don't like rounding on this channel at all? So not necessarily the most fun rotation for me, but this has really been, I think, medically the most challenging rotation of med school, and I'm very happy I saved it for last. Because even after you're done thinking of a plan, at least there is a component where you do, whereas on the hospital floor, there's a lot of like, think of the plan, click a button, and wait and just like hope things happen. There's still some of that, a lot of that in critical care, but there are some pretty brutal bedside procedures. Like, I mean, we were doing bedside trachs and pegs, and I was like, are we allowed to do this? And of course, you get your intubations, art lines, central lines, stuff that like I'm very familiar with in the OR too, which was kind of cool. But I think the biggest thing that everybody needs to know about critical care is it takes a very heightened emotional maturity, and let me explain. So the reason why I say emotional support animal is that it's a challenging rotation in that sense. There's a reason why you see a lot of ICU personnel kind of get burnt out, because I mean, palliative care is always consulted. You're seeing people quite literally on the brink of, well, not really making it out of the ICU, and a lot of patients don't make it out of the ICU. And it's tough because, at least on the hospital floor, you can talk to them, kind of give them some reassurance. But when they're intubated, sedated, and paralyzed, and like, you just don't know how much that they're receiving their surroundings, the best you can do is just give their family some comfort and just do our best to get them better. But it's a place where you're fighting a losing battle a lot of the time, which is not a really fun emotion to have coming in every day. And quite honestly, this rotation is something that like I'm just not gonna have adequate exposure to at all until like residency. And I'm a little bit okay with that, because I definitely think I need to grow, and I'm always getting better at learning how to set those boundaries between myself and the patient stories that I come across, and it's just gonna take time. But this definitely has been a challenging rotation in that regard, I will say. Which is why I have these guys. Hi. What's up? So I actually know a lot of anesthesiologists and also some of my mentors who talk about scaling back at kind of near the end of their career, where they want a more relaxed life. They end up transitioning to critical care, which I kind of understand. It is definitely slower than the OR, but specifically for me, knowing that I want to do pediatrics, I don't know if I would want to do PICU, I think that'd be a little bit too much on me. And also I think there needs to be additional training for that. But just in general, I don't think critical care is for me. Medical school is for exposing you to all the different parts of medicine, which gives you a much better respect and understanding for all parts of the care team. But then another part, especially near the end of medical school, is deciding which parts of the field that you want to have in your daily life and which ones you don't. Having end-of-life conversations is something that I don't want to be a part of my daily life. And the good thing about medicine is if you don't want that to be part of your life, you can choose for it not to be, and you have to work to make sure that you can make that choice. But with that being said, cheers to the last rotation of med school. Over the next couple months, I'll be doing residency interviews, all of them virtual, submitting my rank list at the end of February, and trying to enjoy the life that I think for the better part of the past 6 years I've neglected to enjoy, and all the while somehow convince myself that I earned this. But thanks for watching. It's been quite a ride, and we'll see where the next steps take us.